Mofta, Medical Director Dr. Aftab Sumro, Deputy Medical Director Dr. Omar Shahata, Dr. Amina Muhammad Ali, our Hospital Administrator, our Nursing Director Sister Gladys Babu, and our eminent guest speaker of today, Dr. Mohammed Mojahed Abbas, dear doctors, nurses, and all other medical staff. We are all gathered here to enlighten ourselves on the MERS coronavirus, which will be presented to us by our guest of today, Dr. Mohammed Mojahed. Dr. Mohammed Mojahed Abbas is presently the ICU consultant and the infectious disease at IMC, International Medical Center. He is a triple-boarded American in infectious disease, critical care, and internal medicine. From 2003 to 2007, he was a consultant infectious disease and critical care at King Faisal Specialist Hospital, Jeddah. He was the chairman of critical care from 2003 to 2004. He has held many positions in US, including the medical director of the ICU and infectious disease fellowship program director. For the last 3 years, from 2010 to 2013, he was a consultant infectious and critical care as part-time at International Medical Center and full-time in US. And since July 2013, he's working full-time in International Medical Center. So it's our pleasure to welcome our eminent guest speaker for today, Dr. Mohammed. Please welcome, sir.
Thank you very much. It is really great pleasure. It took me a while to find the place, and really I'm grateful for the invitation. And hopefully you would find the presentation useful and helpful. I wasn't sure. There are many aspects related to the topic that you've asked me to speak about, which is the new coronavirus. There are many aspects, some related to knowing the virus itself, some related to the clinical aspects, and some related to the infection control aspect, which is obviously the big deal. So hopefully I'll have something that every person will find interesting based on their interests. When I presented similar talk 3 weeks ago to our hospital, and I've given this about 3 times, every time slightly different, I decided to call the talk Emerging Viral Infections, because although the interest now is the coronavirus, the MERS-Cov virus, there are really many emerging and deadly respiratory viral infections in the world that are all of interest, and we should not lose sight of these. So that's why I wanted to spend a few moments talking especially about the influenza virus. Just a few moments. So I may be touching a little bit on the virology and the epidemiology, clinical presentation. Probably won't be touching about the laboratory diagnosis since it's not available to most of us. We think we may be able to get it in our hospital soon. This is the topic by itself, therapy, so I'll have one slide hopefully on therapy related, but then a lot of deal on the prevention and infection control. I have spent significant time going over the Ministry of Health website, both in its Arabic version and English version. And really they have reported every single case that they want to report on it. The format is not friendly. I spend many hours extracting the data and putting these in Excel sheet so I can summarize the data in a meaningful way rather than the everyday report that you see, but then it's hard to make sense of the old data. So that's something that you probably can hear only better from a Ministry of Health official that have that data. It is public data, and I think its accuracy probably in the 90% based on my extraction. So I'll share with you these that you probably have not seen before, but you've heard them. So there are many viruses that cause respiratory illness, and many of them, and some of them, may lead to respiratory failure, the same as we hear about the new coronavirus or the MERS-Cov virus. Certainly, influenza virus is all around us. We actually have several patients in our ICU being ventilated as sick or even sicker than the MERS-Cov virus, and they're all from the influenza virus, whether it's H1N1, influenza A, or influenza B. They're all common in our area, and they're all very active. Yesterday, our laboratory director sent us an email that we had 5 positive influenza patients in our hospital diagnosed. The importance, I'll show you in a few moments about the influenza, is because we can do something about it, and there is a treatment for it, but more important, there is a prevention. So after my talk a few weeks ago in my hospital, I was promoting as part of the overall campaign for better health to our employee. We had a vaccination campaign for every employee in our hospital, starting with the frontliners, the nurses in the ICU, in the ER, and those in pediatrics and so forth, to protect them from the influenza virus, and so they don't get sick. So because of the fear of the coronavirus, everybody was lining up in our staff clinic to get the vaccination. So obviously there are many other viruses, they're less common, but the influenza is probably the most significant. So there are many variations of the influenza. You all heard about the H1N1, which is an influenza A. There is the seasonal influenza A, the influenza B, and really very worrisome is the avian influenza in China. There is an outbreak ongoing currently in China. Everybody is worried that if it turns to be similar to the influenza, it's going to be more deadly than even the coronavirus that we know about. So anyway, keep tuned to these. So the reason why I talked so much so far about influenza is to put a perspective, comparing influenza and comparing coronavirus. So what I have here, how many total individuals got infected during 2013 with influenza? 3 to 5 millions around the world. How many so far? Less than 500. We've reached about 417 in the kingdom. How many people died last year alone in 2013? Between 250,000 and 500,000 people died of influenza last year alone. How many people have died so far? It's less than 150. In the kingdom is about 117 now. So perspective wise, and we see it, and I'll show you a graph from WHO, that influenza is around us. So we have to not forget that we can do something about them, and as deadly disease and as common, more common disease that we can prevent. So this is the WHO graph showing different kind of influenza in different areas, and this is the area relevant to Saudi Arabia. What the different colors tells us is that the different types of influenza that I showed you exist, like influenza B, seasonal influenza, H1N1, and other types of influenza do exist. So that's why the different colors in the graph, like the different places. So that's as much as I want to mention about it. And this is the area in China. So if you're going to travel to China, maybe avoid this area in the far, I would say, east, that has the avian influenza ongoing, and which is worrisome to the world, the same as the MERS-Cov virus. So this is how the virus looks like. I'm not going to spend time. It's an RNA virus for those that are interested. There are many proteins on the envelope of the virus. These different proteins that are named are candidates for vaccines. So sometime you may hear vaccine against this protein or that protein. So that's all I want to say about the virology. So coronavirus is not just one virus. As a matter of fact, there are many different viruses. And the one that affects human is the beta virus, which is similar to the SARS virus. Similar but different, close to the SARS-CoV virus that we had. But there are many other viruses that affect animals that actually have been discovered over the last 1,000 years. There are studies, I eliminated that slide, to show coronaviruses have been known since the year of 1200. There is evidence of in animals and genetic analysis. But human infection only started in 2012. Anyway, so I think I have another slide here to show the relationship, how the coronaviruses started in bats and then affected, there's alpha viruses, beta viruses. I think these are delta because I can't see it well. And you can see the coronaviruses that affected the human is actually the same coronavirus that can affect the domestic animals. And that's perhaps why we're seeing it at this point of time. Oh, I have that slide to show that the history of coronavirus is well known since the 1200 years in different animals. So one word to say why human infection now, since it's been around for a very long time. One of the theories, this is the human space, so to speak. And over time, used to be human space separate from where animals would live and so forth in terms of growing. But as humanity have expanded, there has been significant overlap between where these animals are living and where we are living, and therefore we can exchange these viruses, these animal viruses. So whether it's the avian influenza, whether it's the coronavirus, the same theory exists, is because we are getting more than ever closer to animals. So some of the theories obviously in the area, maybe it's the expansion of the camel farmers in farms in the areas in the kingdom that promoted this close contact between more human and more animals. Anyway, so this is the general theory. Why we weren't seeing it a lot before, and now we are very close to animals and bats. All right, put this just as a reminder how this disease and statistics are changing. I keep showing this. This is a snapshot from the website at the MOH, and I think I have the date somewhere, April 19th, because I moved the slides from one presentation to another. And at that time, the number total in the kingdom to 231, and the deaths was like something like 71 or so. Very, very interesting. Now, if you look at the website, same website, you're going to see 417 with something like 117 deaths. So within less than 2 weeks, we've doubled the number of patients in the kingdom. And I'm just presenting official statistics. The second thing that I think may be political, maybe not, that worth mentioning is this statement. You could look, this is, I'm just going to get closer so I can see it, read it. All right. So here on April 9th, situation of coronavirus is reassuring. It is not epidemic. It is not epidemic. Praise Allah. I want to show you that it was epidemic and should have been recognized as epidemic based on the data that I'm going to show you. So that is very important. So the overall mortality, and I'll show you more data, is about 32% in the kingdom based on the older data, and maybe run down to about 30%, much lower than the original data and the original publication by Ziad Mamish a year ago. This time that showed almost a 60% mortality rate. So these are the slides. These are real data I obtained from that same website that I showed you. Anybody can go there and extract every day what's happening in Jeddah and where are the infections being diagnosed. So actually I went through every line over the last year and a half. Plus I added the publications in the New England Journal of Medicine patients. I extracted the data and I put them in an Excel sheet and I generated these graphs. So the first graph that I'm showing now is the history of MERS-Cov in the kingdom. So this is since 2012, and you can see there was one case. Each one of these lines is about one case. So you can see occasionally, last year, this time, there was a little bit over, but you can see clearly here since March, we are going way up. So that's what's called outbreak, is when your rate changes above your baseline is called outbreak. Now, the word epidemic is not a medical term, it's a layman term, but that's the equivalence of an outbreak. We call it an infectious disease and outbreak. So this is for the entire kingdom. This is for Jeddah. And this is why that statement that was there was wrong. Yes, at that time when that statement was made on April 9th, there were maybe 8 cases, 9 cases discovered. Someone would say, what about 8 or 9 cases? We've had already some 100 and some cases. But in Jeddah, we have not been seeing MERS-Cov before. So this is since 2012. We had a single case here. So was one case here in the beginning. Actually, the first case was diagnosed in Jeddah, interesting enough. And then occasionally we had one case, occasionally one case. So there's no activity. And I'm going to expand this, by the way. It's the reason why it looks dark, because there are so many cases within a short period of time when you look at it in a 2-year time frame. So any activities here that you start having more than 1 or 2 cases, you should recognize it as outbreak. And you can see how this looks in comparison with the last 2 years when it comes to our city. So I'm going to show a little bit more expanded version of that, just focusing over the last month or so. Since the first case in March, We didn't have it for over a year, we didn't have a case. And then a few days later, there was a case, March 1st. And then there were 4 cases. So where is March, where is April 9th? Here's April 9th, when that statement was made. Well, these we have not been seen, never been seen in Jeddah. And yes, there were only a few cases, but never been seen. And you know when an infection starts, it starts spreading. And sure enough, it's continuing. And I don't see an end. Maybe this is a suggestion that we reach a peak and hopefully we're coming down. But last couple of days, we've been seeing still few. So we're gonna have to see. We can always tell backward if the rates start coming down. But so far, it has not been coming down. All right, I want to say also that it's not only Jeddah. Right? For some reason, Jeddah got the attention, but Riyadh has been getting as much activity or even more than Jeddah. As a matter of fact, I think Riyadh started first, and the first case probably imported from Riyadh. Somebody moved to the university hospital. So this is Riyadh all along, has been having some activities versus Jeddah didn't have. But then before us, they start, this is before us, and then now they're having as much activity as we do. And this is the MERS-Cov distribution in different cities in the kingdom. And you can see the 2 cities that have the most are Jeddah and Riyadh. They're almost equivalent. Now, 2 cities that we have not been seeing before, the Eastern Province are these ones. This is where it started. These are the Eastern Province. And you can see different towns, but more interestingly, recently, Mecca and Medina start having some activity, which before never had activity. Interesting enough, I would say Mecca and Medina may be more densely populated and so forth, and yet we're not seeing more cases. So that tells me, which is relevant to us, that the transfer so far is hospital-based more than community-based. Because if it was community-based, few cases would have run like fires among people and made them sick. So we have to focus on hospitals and prevent transmission within hospitals. Hospitals have become the centers of transmission of this virus. I'm not saying it doesn't happen outside, but so far, hospitals are the centers. So this is to show that the average age for those that are affected, for females about 48, for male a little bit older, whatever that means. This is just data out of this Excel sheet. I thought I just added this slide a few hours ago, age distribution of mortality. These are the cases of everybody that died in the outbreak. And these are the ages starting from, I think this was 9-month baby that was reported sometime, and then going up to age up to, I think, 94 over there. And it's clearly you can see most of the mortalities are in the older age, more than age of 54. So something that we've learned was published before, and now this data represents the 400 patients, that most of this disease is disease of the elderly and disease of the sick that have underlying medical problems. And that perhaps can explain why the hospitals are the center, because that's where sick people are, that's where the elderly people come in, and they close to each other, and then the virus can move. So this is age distribution mortality. This is all our data, Saudi Arabia data. This is not international data. Okay, so average age according to outcome. So those that die typically are older, average age is 58, versus those that improve are younger. I think, all right. So importance of presence of chronic condition or mortality. So these are the people that die, and 68 people that have chronic condition die. 68% of the have condition die with this infection. Ministry of Health, now that there is an outbreak, they're testing people that are contact to the cases, and they call them contacts. So this data show you, now that there is a report of significant number of people, that almost half, 50 out of maybe 120 almost, 115, 50, a little bit less than half, don't have symptoms of the contacts. So if I'm a doctor taking care of patients and so forth, I have about 50% that I will not even have a symptom, even if I would test positive. And then a little bit more will have symptoms. And I tell you, majority of these symptoms are minimal symptoms, few are severe symptoms. Obviously, there are young people on ventilators. But again, that's emphasizing the fact that it's a disease of the elderly and of the sick people. All right, so this is about healthcare involvement. So out of the whole outbreak, these are the healthcare workers. So about maybe 73 cases, while the majority are non-healthcare worker. So majority are non-healthcare worker. I left here blank, probably these should have been added to these. Blank is when the Ministry of Health didn't say anything, so I did not assign it a category. Sometimes they're not consistent the way they report. All right, and symptoms in healthcare workers, no symptoms, and yes symptoms. That's in healthcare workers. And mortality in case workers, that's an important. You can hardly see it over here. This is healthcare worker mortality. So far, I could find only 4 cases of healthcare workers that died of coronavirus. Many more that have been symptomatic and sick, but only 4 around the country that have died. Why? Because the healthcare workforce is typically young and healthy and typically don't have medical problems. So probably less likely to die. All right. And the outcome in contact, they're less likely, so these are contacts, less likely to die than if somebody comes in with the disease not knowing where they got the disease. Very interesting enough. All right, so how do they present? So I'll spend a few moments, and please stop me because I have a lot of things to say. So if you get bored, say, we've had enough, we can do this later. So I want to, just for the clinicians, is how the clinical presentation, and that's based on the publications in New England Journal of Medicine 2013. So as everybody knows, fever, chills and rigors, cough, headache, myalgia, malaise, shortness of breath, occasionally diarrhea. For some reason in the public, the diarrhea and GI symptoms have been overemphasized. They're probably less than 25% that will come with the GI symptomatology. And these are their test results when they come in on the X-ray. So they can have infiltrates, they can have leukopenia, lymphopenia, low platelets, elevated enzymes, liver enzymes, elevated troponin, I've seen this, and elevated urea, creatinine. So these are the typical laboratories. So typically, somebody with a pneumonia but without leukocytosis and with lymphopenia. That would be your classic MERS-Cov patient coming to the ED. Fever, myalgias, like a viral syndrome, with or without infiltrates, with leukopenia. So I'll skip these. These are repetition. I just wanted to show you this for the clinicians, because when you look at this, we all learned in medical school, this looks like a strep pneumonia, lobar pneumonia. This is MERS-Cov pneumonia. This is from the New England Journal of Medicine publication. And a few days later, it becomes like this. So do not classify patients based on radiology or even clinical presentation, now that the outbreak is ongoing, that this patient may or may not have. If we get a chance, we can talk about what we're doing in our hospital. We've decided to consider every community-acquired pneumonia as potential MERS-Cov pneumonia until proven otherwise, because you cannot tell the difference in many ways. So this is also from the publication. Don't want to spend a lot of times. These are patients in dialysis units. One patient from the community came, gave it to another. This gave it to several people. Few healthcare workers got it and moved between hospitals. This was in 2013 when it was published originally. Obviously now we're living the same outbreak. So this is the Ministry of Health poster about the symptoms: cough, fever, what is this, pneumonia, shortness of breath, occasionally GI symptoms, diarrhea and vomiting. Yep. Okay. Therapeutic options, I'm just going to present this slide. There is no proven therapy for MERS-Cov. Some of the things that were tried before for SARS are now being considered, but there is no evidence that they make any difference yet. I called in when the case arrived to the US. The CDC was giving media announcements, so I dialed in to listen, and they received some questions from CNN, CNBC, and so forth. So one of the questions to CDC, do you have any treatment? And the answer, we do not recommend any treatment. So that is at least the standard of care now in the US. I can tell you in town, speaking with my colleagues at King Faisal and National Guard and other people, everybody is treating with something. So sometimes you may be forced to treat just because other practitioners in town are using treatment. But it's not necessarily effective per se. So prevention and control, a few words. I thought when I presented this to our hospital, there are 4 aspects about control. Prevent the spread between individuals, control the animal reservoirs. Everybody believes the source is animals. So in order to stop this, eventually you've got to control the animal reservoir. So this is beyond us as physicians. Probably other experts can talk about that. We can vaccinate. There is no vaccination yet, but people are working on vaccinations. That's one method. Control, and you can vaccinate the animals. Even if you find vaccinations, you can actually vaccinate animals, so animals do not get infection, and animals then do not move the infection to humans. So these are the 4 basic strategies to control such outbreak, and there are people working on all of these at the same time. So infection control measures could be divided for the public and for the healthcare workers. So this is for everyone, and this is, I thought I'll put in the, and you have them probably on your walls. I saw them on Coming In or somewhere else. So that's what the Ministry of Health recommends, that we think it moves by direct contact, droplets, and contact with patients, tools, and so forth. Now what's additional, this is the vision of the MOH and the WHO, and I think I have a slide on that. The CDC thinks that airborne is possible. So in the US, patients also will be isolated for airborne transmission, like TB would be, in a negative pressure rooms. It is not proven so far. There was some evidence from SARS, but it is a recommendation, and that's what we're doing at our hospital. We're actually building more capacity for negative pressure rooms in case there are many patients, so we can all have them in negative pressure room. That's probably what would take to prevent the infection getting into the employees. So infection prevention for everyone, we would say the healthy respiratory etiquette, and I have a picture on that you're all familiar with. Avoid crowds, frequent hand washing, do not go to school or work if you're sick. So very important. So especially if, let's say, you end having 1 case of MERS-Cov here, and there are some contacts, but they're healthy contacts. So you would tell your employees, if you start feeling sick, you should go to the staff clinic, but not report to work and be off work until they're asymptomatic. Because the last thing is infect the rest of the people, and then you have a big problem at hand. And school is the same way. If you have fever and cough, you probably should not. My administrators didn't like this comment when I gave it in my grand rounds, but it's really important, because I've lived SARS in the US 13 years ago when SARS hit Detroit from Canada. It was a big deal. We ended actually evacuating several floors because some nurses, employees were infected. We ended stopping some surgeries. We ended having some anesthesiologists being exposed so they couldn't go to work, entire OR team. So it's a big deal. The hospital and the healthcare system can go to paralysis if things aren't managed correctly, and then you start having your employee not working. So it is vital to keep the employees as healthy as possible. And here is my pitch is to get vaccination for influenza. It's really essential. It's a preventable disease. The last thing is having an employee gets the infection, gets sick, be on a ventilator, or give it to other people that are sick, and we can prevent it. So we had actually tens of people lining up after the talk getting the influenza vaccine. It is not too late. Some people thought, well, we're late. It's not too late. You can get the other new vaccine when it comes out next year. So this is the healthy respiratory etiquette. Important thing is you don't want to sneeze or cough in your hands, and then you shake somebody's hand or you hold the door and so forth, and you've transmitted the virus, whether it's influenza, MERS-Cov, and then many people can potentially be exposed. Anything then the person touches will move on. So use your sleeve, use a towel, and so forth. So we've talked about this. Washing hands is essential, and I think you all know about this. Avoid touching the eyes. I can't read them from here, so I'm going to read them from here. You wear a mask when in crowds. Avoid contact with patients and their belongings, but from our point of view, that's what we do. So you have to use personal protection equipment when we deal with patients. So when coughing, sneezing, use tissues. Maintain good hygiene habits, and wash fruits and vegetables, and keep healthy lifestyle. All right, so prevention in the healthcare environment, I'm gonna skip over these and I can stop. I don't know how much time you have for this presentation, but I gave a whole presentation for the hospital to advise on how to prevent. So in order to prevent transmission in the healthcare environment, we need to understand how it moves. So I mentioned it's by droplet and by contact, and possibly by airborne. So if you do that by droplet or contact, that means you wear gowns, you wear gloves and gowns, and surgical masks should be enough, and that's what the MOH and the WHO recommend. If you were to believe that airborne is a possibility, then you would have to use N95 masks and use negative pressure rooms. All right, very important to have a plan and need support of administration. I tell you, that is the most important thing. Nothing moves in organizations unless administration are convinced about what needs to be done and part of the planning. You can't have meetings on lower levels and then have disconnect with administration. So I think I may have a slide that with what we call the MERS-Cov response team, it has administrators on it, whether it's the CMO or the CMO assistant and so forth. Because then if we need an equipment, if we need to buy extra masks, the decision is there to say, yes, I agree, go ahead and do it. You don't have to wait and so forth. So administrative support is very important. So these are the essentials. You need to know in your hospital, if you're gonna isolate somebody, is how you're gonna define who has the coronavirus. So you need to establish a case definition. The Ministry of Health has a case definition. I think it's problematic and I think it's not enough. It defines the case definition is for those that have severe respiratory distress, they are in the ICU with pulmonary infiltrate and having pneumonia, who may have some of the symptoms that I mentioned, leukopenia and fevers and the like. And they would not test anybody who is outside the ICU. The problem is a lot of people start their journey to respiratory failure outside the ICU, whether it's in the outpatient setting, whether it's in the ER, whether it's in the ward, before they are sick enough to be in the ICU. So as a hospital, you would need to establish proper case definition, so you identify it, everybody on the front line, whether it's the ER triage nurse, whether it's the receptionist and the outpatient, having a checklist. We've developed a checklist. Do you have fever? Do you have cough? And have you been in contact with somebody with coronavirus? So if you have that, one of these positive, you immediately put a mask on that patient's face. And then before you take them to see the doctors and other nurses and so forth. So anyway, so case definition and a plan is very important. Establish the isolation policy with appropriate education. So I hope that you have infection control and you have the policies, what is droplet, what is airborne, how you do them, and educate the staff on the proper use of equipment. So in case of outbreak, establish triaging policies, and I'll show you a sample triage that we do in our ER. Establish, as a matter of fact, I may skip that one. Establish visitors education, possible. At some point, if you hear that it's being transferred in the community, then you don't want a visitor coming in symptomatic and then going through the ward and infecting the other sick patients and the staff. So you have to establish how you screen visitors. In the US, 13 years ago, we established at the entrances guards that would ask every visitor coming in these 3 or 4 questions. And if they are not essential to come to the hospital, they will be asked not to come to the hospital because we're worried that patients and visitors will come in. So establish contingency plans for the emergency department and the ICU. So the two units that would be the most hit would be the ER and ICU, if this were to come to your hospital, because these are the frontliners and there is more likely to have sicker patients that will infect. And establish policies for staff with symptoms and protected exposure. So when are you going to say to somebody you have to have a fair rule about when you stay home, when you can come back to home to work and so forth, if you have been exposed and so forth. All right, communications, very important through the organization to communicate the plan and so forth. Very, very essential. So elements of the hospital action plan, I mentioned it quickly, and I'm going to stop in a few minutes. The managing team, creating a process for limiting patients and employee exposure with active surveillance, isolation policies, personal protective equipment, making sure that you have it. If you get more outbreak, maybe there won't be enough around to buy, so we want to stack up and have enough of the PPE. And increase hospital capacity for surge. I tell you, I mean, maybe, I don't know your hospital well, but what you're going to do if you have, God forbid, 2 or 3 nurses on ventilators, and your ICU may or may not be able to take care of them. So we had decided to hold certain surgeries, keep certain beds open, because one has to take care of their own employees and so forth, because that's a possibility. One of my colleagues that I worked with at King Faisal Special Hospitals ended being on a ventilator. One of the nurses that I worked with ended being on a ventilator at King Faisal. So it is possible, so you have to take care of. And if your hospital like ours, full all the time, don't have beds, you have to have a plan to have these empty beds in case something happens during the outbreak. All right, and limit hospital exposure, which is town-wide, is to try at the first place not to admit patients with MERS-Cov and send them to the MOH. But in order to do that, you have to have a good screening in the emergency room. And if you have direct admissions, to screen and make sure you're not getting in patients that will end being MERS-Cov. So that's where the case definition and the screening process. And the MOH is welcoming people to send patients to them. King Fahd Hospital, and I think we heard King Saud. So the managing team, who is in the managing team, administrators, infection control, nursing leadership, key department leaders like ICU and ER, respiratory therapy, facility management to make sure that our negative pressure rooms are good, and some others. So I'm going to skip these. These are the symptoms for screening: fever, respiratory symptoms, and exposure to another facility. Patients' entry points to our hospital, and this is not limited: ED, outpatients, direct admissions, transfers from outside. And I added 2 things to this later on: dialysis unit and day surgery. Day surgery could be devastating to have a patient that is infected coming to day surgery, gets intubated, anesthetized, and then find out 2-3 days later that they have MERS-Cov. And then your OR team has been exposed, your anesthesiologist has been exposed, and then you lose these capacities and maybe have exposed other patients. Why? Because during intubation and so forth, risk of exposure becomes even higher. So day surgery is an important entry point to screen. So screen and isolate. So we have a triage. I'm not going to go over it in detail. There's some organization-related aspects. Outpatient triage need dedicated maybe walk-in clinic. Isolation facilities, you count how many you have and maybe of negative pressure rooms and maybe add capacity to it. Personal protection equipments, hand washing, masks, gowns, and gloves. Talked about the different kind of masks. Heard about the surgical masks, and that's for routine, and you put that on patients. N95 masks, and these are for encounters of highly infectious and especially for airborne. And then respirators, and I think we're going to get some respirators where it's like being in a space suit. The only air that comes in would be through a respirator, a filter, and gets in, and there's a hose that connects the hood. So we'll buy a few of these to the ICU and the ER in case we have proven cases. So these are the different N95 masks. They're different versions. They're all the same. They have to be, so important here, put it there to remember about the goggles. In case the practitioner is doing breathing treatment, you should wear something to protect the eyes. Intubation, bronchoscopy, all of these should have eye protection in addition to the mask. And this is the kind of mask that I mentioned, and this is the respirator. It's called powered air purifying respirators. We use these for TB and so forth in the US and during SARS. All right, so increasing hospital capacity, I'm gonna skip it, it's our own, so internal communication, essential, we talked about it, and then I'll stop there. I think I talked too much, so I appreciate this. Any questions, please? I'll be happy. Yes, please.
What is the reason for the sudden increase in the number of MERS cases in April?
Yeah, difficult question, and there are only speculations. So somebody would say that maybe the kingdom now has better ways of detecting a disease that has been already ongoing for a while. So better detection, better surveillance, more sensitive tests like the PCR. So that's one aspect of detecting it, certainly. Another would be animal related. People are really digging deep into the human-animal relationship and whether farming activities at a certain season would increase exposure and so forth. Certainly, as you already seen and heard, the virus do exist in camels and other animals. How exactly it's being transferred is not known. So these are the two top. Infection control practices is probably play a role, but why in this particular season it's not clear. These are at least two. I have seen a couple of other explanations that I don't recall now, but all speculations.
It started in Al-Aqsa, and we are not seeing more cases in Al-Aqsa, and we are seeing more cases in Jeddah and Riyadh.
Yeah, so what I think, right, so, and this is speculation, and I don't have the full data to be knowledgeable about the answer. So my source of data, really the MOH list of cases, which is chronologic, which is very useful. And as you see how Al-Aqsa starts, and then, so I think it got introduced from Al-Aqsa to Riyadh, and from Riyadh it moved into different places. So that is the theory related to infection control. That is patients moving to organizations where infection control is not tight, so allow the virus to spread. But there could be other possibilities related to animals and so forth. And I'm not familiar exactly about the practices, the farming practices, whether it has changed or there has been exchange of animals between different geographical areas. But certainly I've noted when I'm going over this list that you would see somebody starting in Riyadh and then a few days later starting more cases, a few days later getting a rash of cases. And certainly the first case in Jeddah, we think imported from Riyadh, the patient that travels back and forth. Yeah.
Question, we had so many other viruses in Kingdom, and some people were died, and later it subsided and disappeared. Like that, do you believe this virus also will subside after some time and people will get antibodies?
Right. Yeah, you're right. So judging from the SARS experience, that's what we hope will happen. Although it took about 8,000 individuals to be infected worldwide before SARS suddenly died off. And probably because of the inefficiency of the virus to transfer between humans. Not very efficient, even this one. If this virus had the same capacity as influenza, you would literally see thousands, if not more than tens of thousands of people dead. That's why I emphasize about influenza, because it's easy to transfer. These viruses that are coming to us from animals, they're not used to the human host. So they have not adapted well to transmission between humans. The fear, and the CDC commented on that a few days ago, The fear is the virus mutate in such a way that it becomes more efficient and transfer. We have not seen that as of recently from the month of April. One virus got sequenced and published and it did not show any mutations. So hopefully it will die alone by itself within a few months. Yes, please.
Scientific proportions of the influenza virus is mainly because I think because of its ability to mutate and go on infecting the human. And these seem to be much inefficient and weak viruses which just have occasionally causes epidemics or whatever it is that's happening now.
I think you're absolutely right. I think you're absolutely right. The fear is sometimes these viruses, like the avian virus, we're worried that if it changes and becomes efficient, then it's a really disaster. You're right. Thanks. Sorry. Oh, sorry.
How long after infection not to go to work or school?
All right. So has to be, so somebody with an infection that is symptomatic infection. So there are several scenarios. One has infection but no symptoms, and then would say we would wait 14 days from the time of the infection because that's what it takes to develop symptoms. Or it could be 14 days from the last time of exposure. If they have symptoms, if the person has symptoms, then probably 48 hours after all symptoms subside, like we do with influenza. No fever and no cough. 48 hours probably enough. And that's what we're applying in our hospital.
Actually,
Sorry.
first of it was a good lecture, better than reading CDC. So I have two questions. One is, first, when you roam around the hospital, you can see people wearing 2 or 3 masks.
Yeah.
Do you think it's that whether it's doctor or cleaner, everyone is wearing? Whether it's useful or hand washing, which is better?
Oh, hand washing absolutely better.
Yeah.
Yeah, absolutely. Now I'm started becoming amused by how the mask could be worn in different ways. So I've started taking pictures. So in the next month or so, I'm going to have some pictures about how how innovative people are wearing their masks.
Including N90 wearing in the OPD.
Yeah.
We have one goddess in India, that's Hanuman. They're sitting like Hanuman.
Yeah, I wouldn't recommend it.
Yeah.
I go when I round in the ICU, I don't wear a mask. Some of my colleagues are wearing masks just because when you have negative pressure rooms and so forth, you know that the air is going to be fine. And wash hands a lot.
Second thing, you said influenza vaccine. I think that is not related with the MERS. Is it useful, influenza vaccination, is it useful to prevent MERS?
No, it's not useful to, but I meant it's worth mentioning that because that's a more serious and preventable disease. So I'm taking the opportunity to remind people about influenza vaccine. Because we are seeing in our ICU a lot of influenza. Yes, please, sorry.
First question I want to ask about the incubation period of coronavirus infection. Second thing, that when we suspect coronavirus infection and when to transfer the patient to ICU. Yeah. This is what my
good questions. So the data about incubation period is average 5.6 days, anywhere between 1.9 days and about 14 days. So somebody who gets exposed, to say that they're probably clear with about 95% accuracy, it's going to be 14 days. Most individuals develop symptoms within the 5 days, some even shorter. All right, so when to suspect MERS-Cov? It's very difficult, and when you have an outbreak, you have to have a low suspicion. So the way we've defined it for our ER physicians, and that's where the algorithm, I skipped it because that's hospital policy, so I don't want to be violating our own hospital policy, is patients will be screened for fever, and if they have it, that's the first line. They will have a mask on their face, and then the physician will screen them one more time. So that's a nursing screening. Then a physician will screen them, decide they need x-ray or don't need x-ray. If they look good, saturation 100%, and decide they don't need workup, they will just write them a prescription and send them out, quick triaging, so no waiting. And then if they look a little bit sick, they have some crackles on auscultation and so forth, they will be brought to 2 rooms we have in our ER that are isolation rooms. And then they will go for x-ray and so forth. So the case definition, then if they have infiltrates, they have the classic presentation of fever, leukopenia, and so forth. So tentatively they have possible MERS-Cov. And then you try to advise them to go to a governmental hospital. Not always successful, so you end sometimes admitting. And when we admit to isolation. When to send to ICU, it's a clinical decision. When you think you're going to be close to intubate somebody and ventilate somebody. Yeah, so you don't have to put them in ICU right away.
Not once you suspect, you have to shift the patient to ICU.
No, not necessarily. Some people I suspect, I send them home.
Only to shift the patient to ICU in case of confirmed cases.
No, not necessarily, because confirmation is difficult. Deterioration, clinical deterioration. Because the MOH so far, hopefully they'll change their mind. The MOH guidance is not to do the test unless you are in ICU.
Yeah.
So you can't confirm a case unless you're already sick enough to be in ICU. So you can't depend on confirmation. But clinical deterioration, like any other pneumonia, needing more oxygen, tachypnic. But once they start getting sick, tachypnic, requiring oxygen, they go down fast. So you need to move them, sooner than you would otherwise.
So isolation of the patient is the priority.
Absolutely.
In such cases, not to shift the patient to ICU.
Right.
Only patient shift to ICU if complicated.
If needed.
And we are suspecting that the patient will be in need for
intubation. Yes, absolutely correct. Yeah.
Sir, I am an anesthetist.
Yes.
I would like to ask two questions. What is the outcome of the patients ventilated? Then any special ventilating modality is helpful in this patient.
All right, two good questions. So once they're intubated, they're sick, and we think now the mortality rate is about 30%, 35%, with good clinical care that you would do like any other patient. So ventilator modality is like ARDS. You want to use low tidal volume, probably pressure controlled ventilation, and try to avoid, because they get very stiff lungs very quickly. So you want to avoid high airway pressures, but that may be difficult. Judging from influenza, for example, I've had people being ventilated with a carbon dioxide of 100, 125, because if I have to give them more tidal volume to blow off the CO2, their airway pressure is going to be too high. So these are the patients that you want to send and consider for ECMO. And that's where ECMO comes to place, is to ventilate with small tidal volume, and if it's not enough, ECMO will compensate.
Can this virus be transmitted during incubation period or infective period?
Yeah, not known. Really, that information is not known. We probably will find out soon. And that question was asked to the CDC also a couple of days ago, and the answer was not known. The case that arrived to the US is a healthcare worker that works out of Riyadh that flew to London and then to Chicago and then took a bus. So arrived there on the 24th of April, took a bus to Indiana, developed symptoms on the 27th and got admitted to the hospital on the 27th. So he probably, it was a she, during these 3 days on the airplane, in the bus, was in an incubation period. And the CDC now in the process of contacting these people and finding what happened to them. So we'll get some information out of this case, probably in the next few months. Because it's a very well defined, when you're on an airplane, you know who was exposed, you know on the bus who was there, it's a relatively recirculating, so you find out. But not known now, sorry.
Another case was reported in Philippines also.
Okay.
Who went back from Makkah. So what do you expect, what could be the global response in this regard? Because US there is already one case.
Right.
One in Philippines. So
yep.
Indonesia also there.
Yeah, Indonesia there is one, yep.
Is there a possibility of quarantine?
I think nobody's talking about that right now, but what the CDC outlined, the concept now everybody talking about, is called global health security. So whatever happens in one country is likely to affect the whole world, and helping one country helps the whole world. So there is a lot of interest in what's happening in Saudi Arabia on an international level, and controlling the disease here and learning the lessons and so forth. And the hope that this virus turns out to be not as bad. Remember in the SARS, it started in China, pretty quickly went all over. I remember when I was in the US, when it went to Canada, Canada was just a few minutes away. You could cross the border. They were paying significant amount of money for intensivists to work in these hospitals and can't find intensivists because they were SARS hospitals. And there was so much physicians, intensivists were being ventilated and so forth. So it is a global, with global implications. But then it went away. Yes, please.
Insurance companies,
Sorry?
insurance companies,
Yeah.
they have taken some decision for this type of patients.
I am not sure. I think they would treat it the same as any disease, I believe. Yeah. Whether they will compensate for some of the high-end technologies like ECMO, I'm not sure. That was a discussion. Whether they will pay, because it's very expensive to do ECMO.
Prevention is better than treatment. What is the difficulty in manufacturing a vaccine?
They are working on that. So the first, I showed the picture of that virus with the different proteins.
Yes,
so if you look at the scientific papers, scientists are working on vaccination. Obviously, it hasn't been very long, and it seems there are promising targets, but they're not yet in clinical use. So we may hear about them in the next 6 months.
No available vaccine.
No available vaccine.
And no available antibodies.
Okay. Antibodies, on that slide that I show available treatments, the last one was convalescing plasma. So somebody that gets infected and they recover, the thinking is that you can get enough antibodies from that patient and use it like IVIG to treat somebody ill. And that is a treatment modality.
But difficult.
But difficult. Yeah. But it has been used.
Is fever mandatory?
Behind you, he's been raising his hand for a while. Thank you.
I want to ask about symptoms. Sometimes the symptoms of this virus may be severe and sometimes it's less. What about fever in this condition? Fever is mandatory. And if this, sometimes I saw many cases, I'm a medical specialist. Sometimes I saw many cases come with severe cough. After X-ray, there is pneumonia. And in these cases, we suspect and we can take swab or.
Right. So good question. Nowadays, you have to suspect. Maybe 6 months ago, I would say no, it wasn't around us because there was nothing in Jeddah. But now, if somebody who is having fever and cough and infiltrates, you better isolate them from your rest of your dialysis unit, for example, and so forth. Absolutely. And we know dialysis patients are among the highest risk of spreading. The outbreak that was published was one of it, and probably the most common marker for those that get sick and die is going to be the dialysis patients. And there's no way around it, just you have to isolate them. The problem is MOH has not been willing to test patients unless they are in ICU because they were overwhelmed by the number of samples and they couldn't even prioritize it.
If the patient gets involved with treatment and he is not in a severe condition like the preparation of respiration or something like that, you can take treatment or we isolate first. And sometimes all the people fear from this condition. So what we will do, if this, you have patient with pneumonia, I isolate him and make admission for him, or he can take treatment and go home.
Well, that's a clinical practice and a policy of the hospital. It has to be policy. So you could say pneumonia, depends on how, is the patient stable for home treatment? You can send them on antibiotics. If you don't think they're stable for home treatment and needs admission like you would deal with any pneumonia, then you ask your hospital administrators, any pneumonia now that I'm admitting should be suspicious and should be isolated. And if the hospital decides, yeah, we will admit and isolate and we have facilities, then you follow hospital guidelines. If then the guidance to the ER would say, no, if you see a community-acquired pneumonia, do not admit, because we want to minimize exposure, you could then treat the patient in ER, give them the first dose of antibiotics, and then tell them, go to the MOH hospitals.
Depend on leukocyte counts to differentiate between pneumonia and
bacterial and
viral and bacterial.
Probably not. No. And I have discussions with colleagues that dual pathogens can happen. You could have bacteria and virus, you could have influenza and corona, you could have a variety of combinations. Yeah. Yes.
Sir, compared to previous viruses, MERS has killed or infected many hospital staff. What's the reason? Have you conducted any comparative study?
No, I'm only able to see what's public. I talk to my colleagues in different governmental hospitals, and really I don't think there's a hospital spared of having MERS or having C. Even relatively smaller hospitals probably have had them. I had a phone call from one hospital 2 or 3 Fridays ago. I was eating dinner or lunch after prayer, and a person called me, say, Dr. Abbas, I have this patient, has been febrile. He came in with fever to the hospital. So I'm going to describe this case. So he's a guy in his 50s, 60s, came in with fever. We admitted him to the hospital. And then 3-4 days later, he started having respiratory symptoms. He had X-ray. His original X-ray was negative. And I treated him with all kinds of antibiotics, and his fever is not going away. What do you think? And I told him, test him for MERS-Cov. So I called him a week later, curious, and it turns out they tested him, and it turns out to be MERS-Cov, and they sent him to a different hospital. And that was a small hospital patient admitted with woke up for fever. So you would think that's probably what's happening around town. That's probably what happened early in March when people were not alerted. Such patients will come, sit on the floor, they may diagnose with viral syndrome and so forth, and they will spread it around, and then you have more population at risk. Definitely, King Fahd Hospital, that's what happened, because I know stories of people who were in their ER or people in their facilities. Anyway, okay. Thank you very much for your questions. I enjoyed it.
Thank you, sir, for your excellent and a very informative lecture. A big applause once again to sir.
Oh, thank you very much.
I thank you all on behalf of our hospital director, Mr. VP Mohammed Ali, and all our staff who has come in his midst of his busy schedule. Thank you once again, sir. Now I request our hospital director, Mr. VP Mohammed Ali, to give the present to our guest speaker.